Thank you, sir. Respected Dr. Lahane, sir, Dr. Ragini, and all the colleagues. First of all, I am thankful to Lahane, sir, who has incorporated me for this course. And my second books, he has put the forward for that book. Thank you for that, sir. After the basic and some techniques of the nucleus management and advanced, we will go still basic. After we know all these things, still many things happen during the work, and we will see the step by step how to overcome these problems. Now you can see here, this is the first step where we will get the difficulty while putting introduction of the phaco tip. This is not just related to the concept, this is maybe the anatomic position. So just we will not think continuously that the beginners only will get these problems. These problems will be to the everybody who are going to do the phaco surgery because of the many different situations, many anatomical situation also. So this difficulty, and you can see sometimes you can touch the iris also. So all these two important things is mainly related to the position, how to put the phaco probe in through the incision. It should be three-dimensionally centered and properly angulated. This is what we are showing here. After that, the surgeon starts strange at the madam has told the stop and chop technique, and you can see the different ways. Sometimes the stroke may be slow, sometimes surgeon can stuck little bit in the center and suddenly it starts this is the jerky movement, and all these things happening because I have recorded around 25 to 30,000 cases of different types of trench, and we can notice this very, very small. So here one can touch the epinucleus, but what should be the ideal trench? Trench should be in the center, well depth, 2/3 to half to 2/3. Now this is the very, very common difficulty when we start the phaco surgery is the division. You divide by the two instruments, you may divide by the phaco tip and chopper. What is the ideal thing is with the dialer and chopper, because two equal pressure instrument, that is the most important. What is the most important difficulty? Is the pressure. And this is very important. Just again I have mentioned that not just because of the surgeon. I think most important point here that the plane of the incision and plane where we are reaching at the depth is different. When we are passing the instrument through the plane of the corneal plane and we wanted to reach at a depth, if suppose it is a deep anterior chamber, if it is your plane of the nucleus is down, automatically there will be the pressure during putting the two instruments. So it's just a simple trick not to put the instrument straight like that, just make it angulated at a wrist or fingers to reach to the deeper plane to make the division easily. Now placement of the instruments are very important. Now here you can see both the instruments, you can see exactly, and slow, steady, adequate pressure to divide the nucleus completely. Sometimes we can use these pre-choppers to make the equal pressure and to divide it in better way. Now the next step is the hold and lift. Two important and interesting point here is we have to go to the bulk, and we have to, most of the time what will happen, we have not reaching the bulk, but when we reach the bulk also, we are going with a very high speed. For hold, only one thing is needed is the very, very slow speed. You should be in a opposition with the tissue. And what the Lahane sir has mentioned today, to avoid this surge and all that, we have to learn the practice of the phaco with a low vacuum, low flow rate. So be in a position with the tissue, you have to be very slow motion movement at this particular step of hold and lift. And that is very important. If you are with a high speed, you lose the hold, and that is the very important tip, and that's what we are getting the difficulty. Now since last 2 to 3 years, whatever you have seen just now, we have started the recording each and every case by the external video camera at the same time. So what is the important thing what we have came to know here is that your plane of the phaco tip and plane of the tissue If this is not a correct plane, you cannot perform better. Whatever you know, whatever the knowledge you are having, whatever the concept you are having, whatever the machine you are having, this external recording system has given a many interesting points to us. Now here you can see the strange is going on, and if you see the angulation here, there is a slightly deep. See, this angulation is not really correct for the trench. Then just make it flat, parallel to the layers of the lens, and you will see the better trench. See this, if you will not really record our own cases, you do thousands of cases also, the same difficulty many times we can come across. So that's the plane of the tissue and plane of the movement of the instrument that we have started recording, and we are getting the very, very good ideas exactly where we are getting stuck and all. Now you can see here when you are trying to hold, if you are superficial, if it is the, see this is the lifting movement of the phaco tip. So you are going to the plane. So this simultaneous coordination is very significant and very important to have a look to these cases. Now here we are seeing that a removal of small pieces, again the difficulty. This is a very interesting point I came to understand. When we are using the straight tip, because of that difference between the incision site and the plane of the nucleus, many times we are not in a plane of the tissue. Kelman tip has avoided this, and that's why Kelman tip is now a better choice to be in a plane of the nucleus. That's very important. Now while removal of the pieces, many times we have just now Dr. Ragini had shown the flowability of the tissue. When you are just at one point, tissue will come towards you. That's the flowability. Now here is a very simple, this is also last time I have shown this, but I can't spare this slide because that is very important. If there are too many instrumentations inside the eye, your flow rate will automatically cut off. So here is the left side, there is a chopper which we have to need, but that is the reason sometimes tissue stucks under the side port incision. So minimal incisions, minimum instruments inside the eye, this flowability will work at a very, very minimum flow rate even. So that is not needed to keep the high flowability, high flow rate for this purpose. And this is what the madam had shown rightly, that just at a one plane. Sometime if you, this is not a notice, this is the point which we notice, that placement of the tissue, that slide has gone, placement of the tissue, not even in the center, just go towards the incision, little bit towards the center and little bit towards the incision. That is the most ideal site of the placement of the phaco tip to eating of the pieces. Irrigation aspiration, you can see here again because of the position it stucks at the incision, and there are many points here. You are catching the strands, going to the center, again going, see there is the direction, catching this side, but direction is like this. You can see the surge, what the sir has mentioned. This is the typical surge when you are at near the incision. Here there are many points. You can see that you are again the plane of your irrigation aspiration cannula is over the tissue. So you may catch, you may give the pressure on a zonules. So that should be also in a one plane many times. See, here I am in the center, but here my plane of this cannula, irrigation aspiration cannula, is over the tissue. You should go in the bulk. See here, most of the fibers are posterior to the cannula, and some strands of the fibers I am catching. These are, when we record every day, you will get this common difficulty. Here I am aspirating, nothing. I am just stretching the tissue. So that is not good. So that should be all this in a one pen, because most of the time, most of the complications are occurring at this step of the irrigation aspiration. And that is the reason irrigation aspiration is very, very important. Although it seems to be very easy when we shift from manual to automated system, all the time your aspiration port should be towards the bulk of the tissue in one plane, then the complication rate will be very, very less. Here you can see, surgeon try to catch the pieces. And see, we are many times during the irrigation aspiration removing the tissue haphazardly. In one quadrant, if it is not coming, going to the second, then going to third, like that. Usually it is the practice when you catch one quadrant, try to go nearby it, because at that time you are pulling some of the tissues and that will already it is towards you. Try to catch the nearby tissue, that will be more easy to do that. Sub-incisional is always difficult, but there are again the angulations and all that are the tricks. Again, continuously we are seeing here, although the surgeon is doing excellently, but the plane of tissue is not correct or exactly. We see that it's excellent. But if you see this slide, here is the aspiration port, nothing is in front of that. And it is above the tissue. So directly you are pulling the zonules. When we record and when we watch our surgery again and again, you will get these points every day. Every case we will do some 1, 2, 1, 2 like this points. So what's the ideal? See, here in the plane of the tissue, try to go not completely centered, towards the little bit center. Try to go in a one plane. Many times we can also do this. Try to go in a one plane and see the tissue which is nearby. Catch that. So that will be the very easy to remove this cortex and epinucleus. Then the last fiber. Some angulation is needed for the subincisional. This is the coaxial irrigation aspiration. Many times we are not bothered when we are doing the surgery. Now foldable IOL, there are a lot of air bubbles. These are quite continuously difficulties are coming. But we should avoid to do these procedures under the air bubbles. That may cause the complication. Now this is the very typical introduction of the IOL. Many times foldable IOL is not under your control. So many times it placed vertical. Vertical placement of the lens inside the eye is very dangerous. It may damage the PC or it may damage the cornea. If it is a hydrophobic lens, corneal damage is also very dangerous. And you should aware the vertical placement. Suddenly you should at least make it flat, parallel to the tissue, so that they should not hit either PC or either cornea. But sometimes this is again happening, that haptic got stuck to each other. So many things are happening, but just keep patience. Everything will automatically settle and you will get the good result. Now finally I am showing to the revert back after the different videos. Again we will go to the basic, that incision. Many times that's the only one of the important principle in an incision is your direction of the incision should be towards the center. If we will not do with this principle, please try to see what the difficulty can occur, because this is what we are listening every day, but we are not practically thinking or doing. See, this is what I have shown, the strokes of the chopper. If it is not directed towards the center, and if I wanted to go to the inferiorly for doing some work with my chopper, what exactly it will happen? You can see there is a stretching, there is a pressure on incision, and leaking can occur. So that is the important, that direction of the incision should be important. So these are the different ways what we can analyze ourselves to overcome all these difficulties. Thank you for your patience hearing.